are you talking about response rates?
Correct.
Yeah. Okay. Thank you. So what about TMB then? Do you use it now to make any prescribing decisions or treatment decisions?
Again, like most of the extensive stage patients, because they're long-time smokers, their TMB will either be intermediate or high. Okay.
Yeah.
And so currently I check it, but it's more just for information. It doesn't really influence what I do. Okay. Because in the front line, it's not like checkpoint inhibitors is available in the front line compared to chemo. Okay. Maybe when those trials come out, I may change my practice. But again, in the second line, okay, options are so limited. I would use
so in second line, do you then go back and check their TMB status before you decide?
No.
Okay. I see.
Rarely.
I see. Thank you. And just wanted to ask a question about the use of immune checkpoint inhibitors in the second line then. So if a patient is progressing very rapidly, do you consider checkpoint inhibitors, or do you consider checkpoint inhibitors for patients who have a somewhat of a durable response to first-line chemo? Does that affect your decision?
Yeah, that's a great question because I have a patient like that right now.
Okay.
So in that patient, he progressed after a year. So I actually used chemo to try and cytoreduce his disease. And then I switched him to checkpoint. Okay.
I see. But if they're progressing very fast, then my understanding is physicians are a bit reluctant to use checkpoint inhibitors. Is that a fair statement?
I believe that is correct.
Okay. I see. Thank you. Going back to testing, are there any barriers to testing in small cell, for example, obtaining biopsies or anything like that, or turnaround times, waiting times? Are these barriers to testing?
Yes. Because with the small cell, it's hard, because small cell rarely goes to surgery, because most people are extensive stage. So obtaining surgical biopsy is hard. Yeah. And then if you get like a core or FNA, typically these are very necrotic tumors, so the availability of tumor material can be limited. That's probably the biggest barrier. Turnaround times, the platform that we use takes about 2 weeks if you could get adequate sampling.
Okay. But for these patients, that wouldn't be ideal because they're progressing quickly. Is that correct? Or does that affect?
Well,
or do you expect that to affect treatment in the future, let's just say?
I think if checkpoint inhibitors became available frontline, and then if data shows that it's only useful in a certain subset of biomarker selected patients, I do think the 2-week wait time can be significant. What I would do in that setting is I may just start everybody on either chemo plus minus checkpoint inhibitor, and then wait until the biomarker to come back, and then tailor therapy accordingly.
Okay, I see.
So I don't think it's like a deal breaker, but it would be nicer if it's more faster.
I see. So would you? Okay, well, we can talk about some of the emerging agents a bit later, I think. But I want to then ask about if you're aware of any other biomarkers that may have a potential, or any other driver mutations that may have a potential in small cell lung cancer. Are you aware of